So moving on to operative management of these fractures, what type of approach do you usually take for these injuries?
Well, for terrible triads, it's not all the cases are the same. You have to know that some cases you do just the first step of the surgery, and that will be enough. Some cases you have to do 2 or 3 steps, 2 or 3 points of the stabilization, and some cases you will end up with external fixation because even after all you've done, it will be not enough to add to get a stable joint. So we have some approaches that from different ways will get to the same place. There's the direct approach, a bigger approach, and you raise subcutaneous flaps to achieve the lateral injury, like a cocker space. And if you need, you can go all the way through the medial in the same incision in different windows. Here in Brazil, I am used to do different approaches. Usually I start with the lateral approach, the cocker approach for most of these injuries. And the first step of the surgery, it would be to take a look at the radial head, work with the radial head. If I can fix, I have to replace it. The second step, after that, I can have a small idea that if that joint is almost stable by that, or it's completely unstable. So the next step would be to repair the lateral collateral ligaments, especially the LUCL. Most of the cases, I would say that is enough. That would be enough to end up with a stable joint. You have to think that the first step of the dislocation is the radial heads going posteriorly, posterolaterally, and after that, the ulna humeral will get dislocated as well. So sometimes when you avoid the first step of the dislocation, sometimes you get to the stable joint at all just by that. And sometimes after that, if you are not happy and if you're not stable, get a congruency joint, you probably will have to work up with the medial injuries. If there is a small fragments of the coronoid, probably bet on suturing with anchors or transosseous sutures. If the fragment is bigger, I'll probably bet in the fixing it from posterior to anterior. And in this case, it's advisable to use a guide like a anterior cruciate guide, so you are sure that you're aiming your screws in the right place. Or in my case, I like to do in anterior to posterior, not posterior to anterior. I like to do another different, separate approach in the medial of the flexor muscles, medial of the flexor carpet, in ulnar carpet, to get straight to the coronoid. With this anterior medial approach, I can see the coronoid and the anterior capsule with a excellent angle of attack. So I have the best, in my opinion, in my hands, the best way to reduce and to work with that is with this anterior medial approach. Following that, I think that after you deal with the coronoid, if you get a stable joint, that's it. You end up your surgery. You have to remember you have to do what is necessary to do in the elbow. If you do the first step, as I said, and you get a reduced and stable joint, that's it. But if you don't have a stable joint, you have to move forward, go doing more and get more stable, more repair. The next step, I would say that I would say that is a repair of the MCL, the medial collateral ligament, with the anchor transosseous sutures in the medial epicondyle. And for the last, if you really don't get a stable joint, you have to call you are not winning the surgery anymore, and probably have to use a sternal fixation to add the stability you need at last. That's kind of disappointing. You do so much work, and in some cases you have to still end up the surgery with a sternal fixation.
Wow. Yeah, I think that was a very good overview, and you kind of ran through that very well in a systematic way. And I just want to summarize that again for those who are listening. And so we mentioned, the first thing, if you read about it, a lot of people, you can kind of get through all different points of your injury through your lateral approach. And you do the lateral cochlear approach, which is between the anconeus and the extensor carpi ulnaris. And you say through there, you can look and you can see if the LCL complex is avulsed off. You can look and you can see if you have any fracture to the radial head. And then you can also try to get through, the radial head to see your coronoid, fracture, if you could see one. And then you're saying if that's not enough, or you can't really reach your coronoid fracture, that you may consider doing a medial approach. And I know we've read and we've noticed if there's any like basal fractures, or you need a plate on the coronoid itself, that you can go medially and do an approach through there. And we know there are a lot of different options as far as what approach you'll take, but you can split the flexor pronators, you can elevate the entire flexor carpi ulnaris, or there's some reports out there of even just detaching the entire pronator mass from the medial epicondyle and the ridge. And then you also touch base on if it's still unstable after you've done your radial head fixation, after you've repaired your lateral collateral ligament, which you said you can do through transosseous sutures, that you may consider going and repairing the MCL and seeing if that helps with your stability. And if that still doesn't work, then consider adding some adjunctive things such as an external fixator. Now, one of the other things I wanted to ask about was the approach. This is something that we've read about, and I haven't seen it done that often. Jay, you can speak to see if you've seen it done before. But have you ever seen the direct posterior skin incision, where they just kind of raise the medial and lateral flexor, Mauricio?
No, I've seen it in a lecture, a Colombian guy presenting it, but here, me and my friends, I never seen it.
Right.
It was direct posterior approach when I'm dealing with a Montega variant or Montega-like injury, that I'll have to deal with the proximal ulna fracture and the radial head, sometimes to fix the radial head, or sometimes to replace the radial head. The Boyd approach. Taxing slightly laterally to get to the radial head. But for terrible triads, I've never seen the direct approach, although I've read it in a lot of places.
And you just mentioned a thing, something important that I wanted to touch on. And how do you decide if you're going to try to reconstruct the radial head versus